Hello everyone, I'm Catalina Ungaro from Argentina, and I'm going to present about using informatic framework in immunosuppressed or transplant patients for a preferential care route at the emergency department. ED crowding results from an imbalance between the demand for emergency department care and the system's ability to respond. This adversely affects patient health, accessibility of care, and quality of healthcare systems. Additionally, ED plays a central role in caring for immunosuppressed patients, since 14% of solid organ transplant patients visit the ED during the first post-transplant year. In consequence, this specific group of patients require complex care in the ED as priority ED access. Appropriate triage is also timely and important, especially in a high-volume referral center, where delay times could vary according to patient's complexity, time of arrival, or weekday. For all of the above, in May 2019, we implemented a new program called Rapid Clinical Care by Internal Medicine Specialists, defined as a preferential care route for these kind of patients, immunosuppressed patients. This new strategy of preferential care was based on identifying these patients early in the triage process and categorizing them correctly, assigning human resources for priority care. For this, a physician was assigned to this task with exclusive dedication available between 8 and 16 hours, exclusively on business days due to the budget and feasibility constraints. After implementation, we aim to describe waiting time and attention time in ED, as well as to explore the effect on patients' clinical outcomes after discharge. Regarding the setting, the Hospital Italiano de Buenos Aires is a tertiary care university hospital, which has an ED department with 4 areas of care according to complexity. Triage-trained personnel classify the patients in these 4 areas of care. We conducted a retrospective cohort study, including all consecutive adult patients admitted to the ED between June and August 2019. We defined as exposed group those admitted to the preferential care route for immunosuppressed or transplanted patients, and as a control group, those patients categorized with yellow color at triage. This means intermediate complexity, and evaluated during business hours represented the traditional path of attention immunosuppressed patient received prior to the immunosuppressed preferential care route program. We followed up these patients up to ED reconsultation or an outpatient scheduled visits. Eligible patients were captured by using secondary databases. Patient health information is stored currently in a single clinical data repository fed by the Hospital Italiano electronic health record, and eligible patients were captured by using secondary databases. The hospital achieved the HIMSS level 7 as it is virtually paperless facility and accredited by the Joint Commission International. With regard the statistical analysis, waiting times and on-call attention were reported as medians with their IQRs and were compared through the Mann-Whitney-Wilkinson test, considering a significance level below 0.05. The frequency of ED reconsultations was expressed as a cumulative incidence at 48 hours, 72 hours, and 1 week after the index ED visits, and the cumulative incidence of outpatient visits were compared with a test of 2 proportions. So regarding the results of informatic development, we implemented firstly a new specific work list, which allowed physicians to quickly identify these patients and gave them priority of attention. In this image, you can see that each locker aggregates patients waiting to be seen in the different ED areas. Marked in blue is the preferential route blocker. Additionally, we created a structured clinical note in order to facilitate and improve the electronic health records of these patients. This aimed to improve continuity of care and integrated ED care with ambulatory care. Finally, we developed a dashboard that allowed us to analyze real-time indicators to manage and improve the area. For example, on the left, you can see the indicator of number of patients per hour with the most crowded hours between 8 and 16. And on the right, you can see the waiting times comparing the different years. In green, you can see the 2020, where the times of the waiting times were reduced compared to the prior years. Regarding clinical outcomes, in the time frame of 3 months, we received 344 visits of patients through the preferential care route. This represented a median of 6 patients per day. Almost 50% were men, and the median age was 60 years. Most patients were referred by outpatient medical specialists, 63%, while the rest consulted spontaneously and were admitted to the program by triage personnel. Following evaluation by a medical specialist, 5% were re-triaged and 28% required hospitalization. The control group included 585 patients. 41% were male with a median age of 64 years, and of these, 25% ended in hospital admission. Regarding the waiting times, we observed a reduction of waiting times between the preferential care route with a median of 8.48 minutes and the control group with a median of 21.63 minutes with statistically significant difference. And there was also a reduction in the time to discharge from the emergency department. 2 minutes in the preferential care route versus 4.25 minutes in the control group. Also statistically significant. This shows the same with a graphic, a box plot showing the waiting time during the first ED encounter. In yellow, you can see the control group, and in red or pink, the preferential care route, meaning the intervention. Regarding the ED visits after discharge, there were no statistically significant differences between groups as shown. And finally, we observed an increment in the rate of patients attending outpatient consults within 1 week from discharge. You can see that the preferential care route had an outpatient visit rate of 69%, while the control group showed outpatient visit rate of 43%. The new preferential care route was associated with shortened waiting time, improved ED on-call time, and greater rates of scheduled ambulatory follow-up after discharge. Health quality construct in these vulnerable patients consists of 2 fundamental elements. First, continuity of care, and then coordination of care. Continuity of care is essential to agree on decision-making criteria, and coordination is constituted as a fundamental tool to improve care and avoid overuse of the health system. Unfortunately, the ED revisits after discharge remain similar between groups, but it would be interesting in future studies to explore long-term effects on either clinical outcomes of interest. Our major limitation was based on a small sample of a single center, but we have to mention important strengths. Firstly, we use secondary databases with exact times. The electronic health record has the ability to generate a complete record of the clinical patient encounter. Secondly, it represents a clear example of data warehousing used to analyze patterns of clinical data to improve quality of care. patient safety and care delivery efficiency. We sought to share the lesson learned since we found that this project combines an informatic frameworks with concept of coordination and continuity of clinical care for a particularly vulnerable patient population. We hope our experience in this field bolsters other initiatives to improve clinical processes and quality of care. Well, I want to thank all healthcare workers at Hospital Italiano ED, the informatic team that helped build the informatic framework of this project, and the internal medicine investigation area, and the RACE team, the preferential care route team that worked during the implementation and during the pandemic with this special group of patients. Thank you very much.